Mhm. Well, I think we can get started this evening. Let me extend a welcome to everyone who's joined us so far. A special welcome to those of you who participate in infection control on either of the two Sovah Health campuses, as well as those that work in our lab systems. We're especially happy to have you join us this evening. The program this evening will carry 1.5 hours credit of Category 1 Physician CME credit, and also 1.5 hours of nursing CE credit. Sova Health is accredited by the Southern Collaborative Association for CME, for Physician CME, and by the Virginia Nurses Association for nursing CE credits. One point to be made is the nursing credits this evening also include 0.75 hours of pharmacology CE credits. The program was developed to promote several desirable physician attributes, including our providing patient-centered care and employing evidence-based medicine in the care of our patients. The needs assessment for the program tonight came from the ongoing quality improvement efforts of Sova Health to promote antibiotic stewardship, and for the program this evening, antibiotic diagnostic stewardship. Dr. Cohen, Dr. Mooring, myself, and the members of the Sova Health CME program have nothing to disclose as far as commercial relationships. There is no commercial support for the program this evening. It is supported by an educational grant from the Ralph Landis Medical Education Fund, which resides at the Danville Community College. This fund was created by Dr. Landis upon his retirement from active practice of urology. He was the founder of the local Southside Urology Nephrology Group. His generous donation upon his retirement has allowed there to be an endowment to support honoraria for medical education throughout our community. I want to make a really big point, so everyone listen up. This is important. We've had problems with our registration system, and instead we had open access for the program that each of you used this evening, and we thank you for your flexibility. Please understand that unless you put your name in the chat now with your email and your professional designation, meaning whether you're a physician, nurse, nurse practitioner, if you don't put that in the chat now or during the program, we will not be able to give you credit for your attendance and or send you an evaluation form. So take a few minutes whenever you want to during the program and put that in the chat. Last time when we had a program 2 weeks ago, we had two individuals we could not identify because they didn't provide the information. One was known as Nick. So if Nick is back with us tonight, tell us who you are, and we're more than happy to go back and get you credit for the last program. Throughout the evening, please be sure your microphone is muted. I also like to always take a moment to thank those that actually helped me make these programs possible, and that is Vinay Mayo, who is our CME coordinator, who truly has done a great job in us with this workaround about registration, along with Jennifer Goodman, who manages nursing education and helps us so much. I'm very indebted to both of them for our ability to do the programs. There are going to be two ways you can access the evaluation form at the end of the program. Vinay will put a QR code in the chat box towards the end of the program, and she'll also have a typed out link that you can click on. Either of these will take you to the evaluation form at the end of the program. When you fill out that evaluation form, which we really ask everybody to do, it will ask you to re-enter your full name and your email address please give us your full name on the evaluation registration form, because that's what will be on your CME certificate. So if we don't have it there, we're not able to generate the certificate for you. The evaluation form you'll receive has 7+ questions on it. Number 4 is the one that we are especially interested in. What changes will you be making in your practice based on what you learned this evening? That is for everybody, not just the physicians or nurse practitioners. We all practice our healthcare skills within our scope of practice. So tell us how the information you gleaned from this evening's program is going to be used in the work you do on an everyday basis. For Sovah Health medical residents, FYI, you do not have to keep up with your CME certificates. We notify your coordinator that you have been on the program. Otherwise, we will email CME certificates once we receive the evaluation forms. Also, a heads up for the nurses and nurse practitioners, in order for you to receive CE credit, you must submit an evaluation form to us. Both of our speakers have asked that you put your questions into the chat. Vinay will be monitoring that, and as they come in, she will appropriately feed them over to the speaker, and or towards the end of the program, we'll have Q&A then. But please, please, please do let us know if you have a comment or concern. We very much want it to be a back and forth discussion type situation as questions arise. When you do ask your question, be sure and mute your phone in order if you did it verbally, so that we don't have feedback. I'm going to highlight for you one upcoming program which will complete our current season of infectious disease topics. In 2 weeks, on April 9th, Thursday evening, Dr. Nicholas Turner of Duke University's Infectious Disease Group will be talking about the increasing prevalence of tuberculosis. This is a disease, when I came through medical school, was a very prominent illness. It sort of went away a lot due to a lot of great public health efforts, but over the past 1 to 2 years, the number of cases of TB has been increasing. And for many of our younger healthcare providers and healthcare professionals, tuberculosis is just not something they have seen, even in their training. So Dr. Turner is going to come and review that for us. That being said, this evening we will have 2 presentations. They both are centered around antibiotic stewardship. As I know many of you on the call know, we have been part of the Duke Antimicrobial Stewardship Outreach Network since its actual beginning, well over 20 years ago. This has been an important part of Sovah Healthcare, providing safe and, if you will, evidence-based medicine in the area of infections over the years. And each year we have an update on this about data coming specifically from the Sovah Healthcare Center. Our first speaker is Dr. Ariel Cohen, a member of the infectious disease group at Duke and a member of DASON as it's known. She began her educational journey at Carnegie Mellon University, where she received her bachelor's degree and graduated cum laude. She then she finished her MD degree at Loyola in Chicago, where she was selected for the Alpha Omega Alpha Society. For those who've been on our programs before, you know this is the equivalent of Phi Beta Kappa in medical school. It's a tremendous honor. She followed that by internal medicine residencies at Loyola, where she was selected for the first year as the intern of the year, and then towards the end of her residency received their award for dedication to patient care and commitment to medical education. She chose to stay on another year at Loyola, serving as chief resident of quality and patient safety before coming to Duke for her fellowships in infectious disease. She is an extremely talented physician who we're delighted to have talk with us tonight about an update on antimicrobial stewardship, specifically for Sovah Health on both campuses. So Dr. Cohen, thank you so much.
Thank you so much for that lovely introduction. I really appreciate it. And thank you all so much for being here. Is everyone able to hear me okay? Sound is coming through okay?
Yes, ma'am.
Fantastic.
Slides look
Wonderful.
great.
Love it. Um, well, I'm so excited to get to talk to you all. And when thinking about how best to approach tonight and talk through this antibiotic stewardship update, what really resonated with me is I've had multiple conversations with colleagues recently, not in infectious disease, who often struggle with the decision around uh, antibiotic stewardship and in balancing how do you make decisions that are feel like you're upholding this kind of global moral best interests with like the patient that's in front of you. And the argument that I want to make tonight is that very often we can make really wonderful stewardship decisions that are really the best choice for the patient that's in front of us. And there's a lot more data that's been coming out to support this. And so this is all through the lens of how do we best take care of the patients that we're seeing. And I'll talk a little bit about why I think stewardship is important in this lens, and then go through an empiric selection framework or how I at least approach thinking through what kind of empiric coverage my patients might need. We'll spend a little bit more time talking specifically about MRSA and Pseudomonas coverage, and then we'll go through just a few high yield cases talking about community-acquired pneumonia, undifferentiated sepsis, and diabetic foot infections. And so what makes it hard to prioritize stewardship, especially in empiric therapy? Well, for one thing, as a generalist, the amount of information that you're asked to know is remarkable. There are new guidelines coming out all the time, probably more than 160 per year from this, study published in 2013, just from specialty societies, not even from our general internal medicine societies. And then guidelines become outdated. And this is true for infectious disease and for stewardship as much as it is for anything else. It's an evolving space and it can be kind of hard to keep up sometimes. And then on top of that, there's so many patient expectations when it comes to antibiotics. And when you look at the qualitative data on patients speaking about their experience with antibiotics, and the description that's often used is it's like gold. Antibiotics are like gold. They're hard to get, and they make me feel better, and they turn everything around. And so that's a tough conversation to have, and it takes time to have it. And if we don't believe in what we're doing, then we certainly aren't going to be able to convince our patients of it. A lot of times there's diagnostic uncertainty. And it's very rare that a patient presents and says, I read the textbook and here's my problem, and this is exactly what you need to treat me to make it better. We're operating with complex
Thanks, I wish you
situations.
were coming.
Um, Campaigns that we may interact with can sometimes seem to have opposing goals. So sometimes we might feel pressure to meet a certain requirement
Yeah,
in one campaign, and then maybe in a different campaign we're hearing different um, expectations, and sometimes that burden and that conflict can be really tough to navigate. I think individuals often feel like, gosh, antimicrobial resistance is this huge, complex global problem. Like, how can my decision today change this? It feels like how can I really make an impact here? And and then also, even on top of that, it comes back to this idea of I have to take care of the patient in front of me. I care about public health. I went into fields of medicine and nursing and healthcare because this mattered to me, but I have to care about the patient in front of me. And what it really comes down to is the harm to an individual patient, this patient we're taking care of underprescribing. It's immediate, it's attributable to the individual clinician. I know I've certainly been there thinking, I'm admitting this patient to the hospital, and my colleagues are going to read my notes and they're going to see my decisions, and they might second guess what I chose, or um, maybe what I chose wasn't right, or I didn't predict how things would go, and things don't go well. And because I made that choice on day one, and the patient or the patient's family is upset with me. I mean, those are immediate responses that I think they are often at the forefront of our minds when we're making decisions. Whereas the harm to an individual patient of overprescribing is often delayed, it's diffuse, it's hard to attribute it to a single prescription. We certainly have all seen hospital problem lists where you could point out 5 or 6 things that maybe were related to antibiotics or to just polypharmacy in general, but that's a lot harder to go back and say, oh, well, maybe if we had stopped the vancomycin on day 2, that wouldn't have happened. Most of the time, it's harder to make those calls. But I want to make the argument that stewardship doesn't just matter to the world, it matters to your patient. So there was an analysis about 10 years ago at this time that looked at how adhering to empiric therapy for antibiotics was associated with mortality. And there was a 35% relative reduction risk when there was guideline adherence. And when therapy was de-escalated, there was a 56% relative risk reduction in mortality. This data was mixed. A lot of it was lower quality just because it's hard to create these studies and to have really rigorous studies on this. But I think a lot of this makes sense when we think about what the potential health benefits are. We can avoid adverse drug events, whether that be nephrotoxicity or IV infiltrations. We know that C. diff is certainly highly correlated with antibiotics, and that can be a devastating infection. And more data is coming out now about how our choice of antimicrobials really can affect the diversity in a patient's microbiome, and the impact on health of that is becoming more and more elucidated. Patients, and something else that I'll touch on a little bit later is that many of the infections that patients end up getting didn't necessarily come from contracting it from somebody else, but from their own flora, from the own microbiome of their skin, of their bladder, of their lungs, and something causing an imbalance that their immune system is no longer able to keep it in check. And so when we minimize the amount of exposure people have to antimicrobials, we also are making a change in what kind of resistant commensals and future infections that patient might get. And resistant infections they're hard to treat. They have higher mortality. They're associated with significant psychological distress for patients. Patients in the hospital are often isolated when they have resistant infections. We have contact precautions. And even when they leave the hospital, I find when I talk to patients in that outpatient setting, they carry the stigma with them. They worry a lot about passing on their microbiome to their families and their friends. And it doesn't leave them emotionally, even when we treat the infection. And then I'll make the point that it's really hard to think about the world, but we can think about our local community. And the patients that we treat in our clinics and in our hospitals, they go back to the community. And we know that there's spread of MDROs, multi-drug resistant organisms, in the community setting as well as in hospitals. And so as clinicians in a community, I think that we do have some obligation to think about how are our decisions affecting our community as a whole and our patients who live in that community. And then we know that each additional day of antibiotic therapy is associated with increased adverse events and increased risk of antimicrobial resistance. So even if we can't always make a choice up front that's narrow, when we have the opportunity to de-escalate as the days go on, we really can make a difference for patients. So I hope that I've convinced you at least to start on this journey with me and to think about it. And let's talk a little bit about what a schema can be when we're not quite sure what to do. Somebody comes in sick, they're in the ER, they're in our clinics. And I think it's important to remember that there's probably a lot that you do know. Many times we're able to make some guesses about what infectious syndrome is present and what part of the body might be affected. And sometimes we're not able to, but even being able to call out, hey, this is sepsis and it's undifferentiated, gives us information. We can often identify patient-specific risk factors, whether they had prior infections or colonizations, not colorizations, sorry, that's a typo I missed. Whether they're immunocompromised or they have other anatomical risk factors based on, for example, prior surgeries or stents, hardware. And we can look at what the local microbiology and guidelines support. And then the other thing we can do on day 1 when we're making these decisions is plan an exit strategy. So just like when you admit a patient to the hospital, you're thinking from day 1, what does it look like for them to leave the hospital? We can be doing the same thing with our antimicrobials. We can collect data early on that will help us de-escalate later, and we could set a timeline for revisiting the plan. I will acknowledge that sometimes revisiting the plan is harder in an outpatient setting, and we can talk a little bit about strategies for that as well. So looking at the Sovah Health data, this is looking at Sovah Health at Martinsville and Danville compared to the other hospitals within our DASON network. And you can see that we have fairly high usage here of anti-MRSA agents. And so this is an area that we want to focus on and at least consider, is it something that we can potentially reduce? This is looking at the prevalence of community onset MRSA across the network. And this is a little hard to read. It's not exactly optimized for this, but these are basically just codes for different hospitals. And then this is the prevalence of MRSA. And so we can see that this here is Sovah, and the community onset MRSA rates are really quite low compared to others in the network. And the ones that have nothing, it's essentially that they didn't have any labs to support that. But it's lower than a lot of others in the network. And so I think there probably is an opportunity here. So going back to our diagnostic schema, again, we're going to think about what's knowable, what is the infectious syndrome, what risk factors exist, what do our local microbiology and guidelines support, and then how are we going to plan an exit strategy? So this is data collected from a variety of different studies, just trying to pull together some of the general MRSA prevalence within the US broadly in different syndromes. And this is not all infectious syndromes, it's just some that we were probably likely to come across. Intra-abdominal infections, it's incredibly rare to have MRSA involved. It's almost never in community-acquired infections, and when it does happen in intra-abdominal infections, it's mostly associated with more surgical or hospital-acquired situations. It's also incredibly rare in urinary tract infections. It happens occasionally, and when it does happen, it should always trigger our thought that potentially this is actually a quieter MRSA bacteremia, and that there's spillage into the urine, and so it should always prompt us to think about getting blood cultures in these situations. And it does happen, particularly in patients who have long-standing catheters, but it's not common, and certainly not common in the community. Even in undifferentiated sepsis, it's quite uncommon to have MRSA involved, but when we think about whether we need empiric coverage, it's going to depend a lot more on presentation and individual patient risk factors. And the same for community-acquired pneumonia, that it's quite rare. It's a lot more common to isolate Staph aureus in hospital-acquired pneumonias, bacteremias, and purulent skin and soft tissue infections.
Yeah, Sister Dan Brown, McLaren Funeral Home. And I'm here to pick up Donna
and even
Hill,
those, it's not that it's
but
always
I'm not
MRSA,
sure
it's
I'm in
just
the
that we're
right
thinking
spot.
about Staph aureus infections in general. Whereas in non-purulent skin and soft tissue infections, it generally is not a Staph aureus-based infection. We're thinking more strep there. And this matches so well to our empiric treatment therapies. I'm so sorry that I think my phone is going off. I apologize. Let me try to make that go away. I'm so sorry about that. So this matches really quite well to our empiric therapy guidelines that we have for Sovah Health. When we look at, for example, in hospital-acquired pneumonia and ventilator-associated pneumonias or purulent cellulitis, we are thinking about using MRSA coverage empirically upfront. In these patients, this is something that we're really thinking about, and we're probably going to start. But when we're thinking about, for example, community-acquired pneumonia, if a patient doesn't have a prior risk factor, like a prior positive MRSA culture or NAIRS, then we really don't, even in inpatient therapy, need to start with MRSA coverage the vast majority of the time. And in the outpatient setting, we really aren't thinking about starting MRSA coverage. Generally, MRSA pneumonias are quite aggressive, and so it'd be pretty unusual to see somebody stable in the outpatient setting who had a MRSA pneumonia. And this is just taken from UpToDate. I thought it was a lovely compilation of the risk factors for invasive and non-invasive MRSA Staph aureus infections. And so again, thinking about patients who've been hospitalized, who've had surgeries, who get hemodialysis, and there's certain exposures that are more associated with MRSA skin abscesses rather than more invasive infections, and that's really a separate component. And then talking a little bit more about colonization as a risk factor. So this is something that we often use to decide whether we're going to start empiric therapy if a patient had a prior culture or had a prior positive MRSA. MRSA nasal PCR is really a wonderful tool in pneumonia. It has a great negative predictive value, especially in respiratory infections. And so it can be used for de-escalation. So we really like to get that early on in the hospital stay. Antibiotics can affect the sensitivity of the test. It's still a very good test, even if you've gotten antibiotics and even if you've gotten, for example, like topical ointments designed to decolonize, it's still a helpful test. It doesn't need it's a PCR test, so it doesn't have to be living bacteria to detect it. It doesn't have as great positive predictive value. And what I mean by that is even when it's positive, that doesn't mean that MRSA is what's causing your disease. And people can be colonized and have infections from other things. And generally speaking, if your patient was not very sick when they came in and they improved quickly, and then never made enough sputum to send a sputum culture, the likelihood of it ever having been a MRSA pneumonia is much lower, even if your MRSA NAIRS is positive. And so I think knowing that can still help with de-escalating as people are improving and getting further along in the hospital course. That being said, it's not as helpful a test for some other conditions because geography really matters. The nasal PCR works well for pneumonia because you're testing for carriage in the nasal cavity, which has a direct anatomic pathway to the respiratory tract, versus when you're thinking about, for example, a foot infection, a nasal PCR swab is not going to be able to give you as much information on that. And they've done studies to demonstrate this. And truthfully, even in wounds, it still has a relatively high negative predictive value, but it's not going to be as reliable. We're talking about lower 90% for that, versus when we're thinking about pulmonary infections, we're in the higher 95% and higher for negative predictive value. So thinking about de-escalating, again, we're not always going to be able to stop doing our MRSA coverage up front, but I do think many times we have an opportunity to stop MRSA coverage. And so I think reviewing cultures in a timely manner is really important for this. And if we have a negative MRSA NAIRS, or if we have other identification of organisms that are causing disease, many times we can peel off our MRSA coverage, particularly when patients are improving. And this is a really great time also to consider switching to an oral regimen. So even if you feel like you still need MRSA coverage, and depending on what the clinical situation is, an oral regimen may be appropriate. And sometimes we might be able to peel it off entirely would be in cases, and we'll talk a little more about this, but in undifferentiated sepsis, if a patient is clinically improving, you have negative blood cultures at 48 hours, that's a great opportunity to peel it off. If you have a patient with pneumonia who's improving and you've got negative MRSA NAIRS, again, a great opportunity to take off our MRSA coverage. Or again, if you've found another organism that's driving disease. Some more easy wins. So just to recap, that most patients with community-acquired pneumonia do not need empiric MRSA coverage. I think particularly when you're thinking about a patient in the hospital, one of the benefits that we have is that you really can watch the patient over time. And if they're not improving, if things are going in the wrong direction, you always have the opportunity to add coverage later. And so I would just suggest that in most of our patients with CAP, we really don't need to start with empiric MRSA coverage. And it's almost never indicated for intra-abdominal infections. So that's another opportunity where I think sometimes people come in quite sick and we know off the bat that there's something going on intra-abdominally, and we start broad spectrum, and broad spectrum is appropriate, but we probably don't need MRSA coverage specifically. When the nasal PCR is negative, empiric MRSA coverage can be discontinued in non-severe CAP. And then it's not indicated in non-purulent cellulitis. So if somebody has a non-purulent cellulitis, and we don't have to have MRSA coverage for that. I'll pause for a moment before we go to Pseudomonas and just ask if there have been any questions on that. Okay. So then looking at our data for Pseudomonas, again, we have some higher use compared to some other hospitals in the system for Pseudomonas. Unfortunately, I don't have a comparative chart that like we had for MRSA to look at what the prevalence is of it in the community. But again, I think just another opportunity to revisit our decision making and think about if this is something opportunity we have to de-escalate or maybe not start. So again, going back to the schema, thinking about what we know, what are the risk factors, what our local microbiology and guidelines support, and then planning an exit strategy. So similar chart as to MRSA. There are a lot of hospital-acquired infections in which we worry more about Pseudomonas, and generally it's less common in the community. So particularly thinking about things like urinary tract infections or community-associated intra-abdominal infections, those are going to be a lot less likely to have Pseudomonas implicated. It's also pretty uncommon in community-acquired pneumonia or sepsis as well. And generally, for skin and soft tissue infections, we don't worry too much about Pseudomonas. It can happen in patients who have burns or surgical wounds and highly immunocompromised. It can play a role sometimes in diabetic foot infections. We'll talk more about that. But generally, it's not something we think about for like a cellulitis in the community. And this again maps really well to our empiric treatment guidelines for Sovah. So again, looking at we're having empiric coverage in hospital-acquired pneumonias and in hospital-acquired intra-abdominal infections. We're also going to use an agent that has pseudomonal coverage. But in community-acquired pneumonia, most of the time we really don't need to. The exception being if a patient has had a prior Pseudomonas isolated from respiratory cultures, then that would be a situation in which we'd likely want to start empiric coverage, especially in the hospital, if someone's sick enough to be admitted. But in urinary tract infections, we really don't need it as part of our first line therapy for the vast majority of patients, unless they have had it recently isolated on a prior urine culture. So this was a campaign that I think you all have seen before, and I just wanted to kind of bring it back to your attention. This was a risk score that can help identify patients that are at high risk for both Pseudomonas infections as well as infections with ESBLs. And for scores of 0, the risk of having one of these infections was less than 5%. The data actually that the study came from supported even up to patients who had 0 or 1 points really didn't need empiric coverage. But I think in Sovah Health, we've implemented it for scores of 0. Those patients likely don't need broad spectrum antibiotic coverage. So just some things to consider, is my patient severely immunocompromised? Have they gotten a bloodstream infection after more than 5 days in the hospital? Do they have recent antibiotic use within the past 90 days? And do they have a history of a prior ESBL infection? Some more easy wins. We can skip empiric dual anti-pseudomonal coverage in hospital-acquired pneumonia. The vast majority of patients will do well with a single agent for Pseudomonas. So we don't have to start with using 2 agents. Most patients with urinary tract infections do not need coverage for Pseudomonas. Most patients with community-acquired pneumonia do not need coverage for Pseudomonas. And then when you find another causative organism, that's a good time to de-escalate. I think sometimes we keep going with the broader antibiotics just because there can be some inertia there, but many, many times we're able to narrow or even oralize once we've identified another organism. Okay, so I'll pause again. Any questions on that? Okay. So I wanted to talk through a few, go a little more in depth with a few different presentations. So thinking about community-acquired pneumonia, the American Thoracic Society released a new clinical practice guideline this year. We did a DASON newsletter on it a couple months ago. And I'm going to pull out some of the information from there, but what I wanted to emphasize here was that similar to what I talked about earlier, our model of where infections are coming from and how we treat them is changing. And I really love this quote that as our model of lung infection advances, the goal of antibiotics may no longer be to completely eradicate causative pathogens, but rather to reduce bacterial load with as little disruption to the microbiome as possible. And I think this just reemphasizes that bacteria live in us and on us, and our goal can't be to get rid of it completely. That might not even really be a beneficial goal, but we're trying to reestablish some equilibrium for the body, and so we want to do it thoughtfully and help patients through their infections without causing long-term harms. So just recapping the community-acquired pneumonia empiric choices at Sovah Health guidelines that we have. We're typically in the hospital starting with ceftriaxone and then doing something for atypical coverage. So azithro is the first line in our guidelines. Some folks prefer to use doxycycline, or that might be appropriate depending on the patient. And then in the outpatient setting, we have our cefuroxime or azithromycin as options. Again, just reiterating with community-acquired pneumonia, we can get those mercenaries early, and that can help us off-road. We can also stop Pseudomonas coverage if a patient's not producing sputum, we don't have sputum cultures, and they're improving. Or if we do have cultures and it's not growing Pseudomonas, then that's an opportunity as well. And PO medications can often be used in community-acquired pneumonia. And so considering that switch as patients are clinically improving is a really good opportunity. And the ATS guidelines have suggested that actually even a shorter course than 5 days is appropriate. And the key to this is patients need to be clinically improving to have a shorter course. So for non-severe CAP, we can go as low as 3 days for treatment. And this is both in the inpatient and outpatient setting. Now, I think the challenge with this is that in the outpatient setting, it can be hard to reassess on day 3 if a patient needs 2 additional days of antibiotics. And so I think maybe that's a little less practical, though I'd be curious to hear from our outpatient providers if they feel like that is something that would be feasible to implement. But certainly inpatient, if a patient has largely resolved their infection by day 3, that's an opportunity to be able to stop antibiotics early. I want to emphasize that this is not for organisms that require a longer treatment duration. So if you do have a patient who has a Staph aureus pneumonia or Pseudomonas pneumonia, that's not the patient to do 5 days in. We're thinking longer courses, more like 7 days for those patients. But for many patients, 3 to 5 days is going to be appropriate. I was so excited to speak to you all about undifferentiated sepsis, and I combed through all of the recent literature on it and was like trying to pick out what is going to be the most exciting to talk about. And then 2 days ago, the Surviving Sepsis campaign dropped their guidelines. And I will admit that I have had a chance to read some of them, but not all of them. But in reading them as I was preparing these slides, what really stood out to me is that there's so much that is in consensus with antimicrobial stewardship backbone. And I think there's just more and more data that's coming out that is supportive of thinking through early de-escalation strategies. And so we'll talk a little bit about that. In terms of some of the literature, this was a study that looked at how often are we using really broad spectrum antibiotics compared to how often are we finding them. It was a cross-sectional study. It included 6.3 million adults in the US across 241 hospitals. And they looked at a prescription of anti-MRSA agents and anti-pseudomonal agents for suspected community onset sepsis, and found that half of all of those agents were prescribed for this indication of community onset sepsis, but less than 10% of community onset sepsis actually had those resistant organisms identified. And I just think this points to it's so challenging, right? When you have someone who comes in sick, how do you decide how broad you're going to be? You're worried about them, they're sick. You don't want them to decompensate. You don't want them to lose their life. Sepsis is a serious condition. But there's this gap where we are prescribing a lot of antibiotics for this, but we're not necessarily always finding it. So how do we approach this safely? And I think a key to this, in addition to thinking about, okay, what is the condition that I'm thinking about and the patient and their risk factors, and maybe I'm not always going to be able to be narrow up front, but how can I narrow as the days go on? How can I make that decision a few days in? And I thought this study was really interesting. It was a quality improvement study, so it's observational. And they looked at patients across 67 hospitals, and they took patients who had gotten either or empiric MRSA coverage or anti-pseudomonal coverage. So patients could have been prescribed it either MRSA or pseudomonal coverage or both. But then they took all of those patients and said, okay, of those, which of these patients didn't have some sort of positive culture or MRSA test by day 2? And then in those patients who we haven't isolated these infections, what are the outcomes in those who were de-escalated by day 4 compared to those who were not de-escalated by day 4? And what they found is that mortality was the same in the overall cohort. So in patients who were started on these empiric therapies and did not have a culture that identified this infection by day 2, if they were de-escalated on day 4, they had similar mortality outcomes as those who were not de-escalated. And in the group that was clinically stable, so they were improving, they weren't in the ICU, and they were generally doing pretty well. And those patients, the mortality was actually better when they were de-escalated at day 4 compared to when it was continued. And again, this is an observational study, and so there certainly could be other things going into what made this these differences, but I think it does point to the safety of de-escalation in most patients when we haven't identified the organism by day 2. That even in patients who come in with undifferentiated sepsis, we can still make the decision to de-escalate when they are improving. And when they looked at secondary and exploratory outcomes, the big difference was that patients who had de-escalation had fewer days of antibiotic therapy and they were discharged from the hospital quicker, which we also love. That's also great when that can happen. And so looking at the Surviving Sepsis Campaign guidelines, there was a few updates that I think are relevant here. And so just as we've been talking about being thoughtful about our patient and what their risk factors are, and if they've had a prior isolate that showed, for example, MRSA or Pseudomonas, we're going to be more likely upfront with sepsis to use something to cover those microbes. So for adults with sepsis or septic shock at high risk of infection with a specific pathogen, multi-drug resistant pathogen, we're going to use empiric antimicrobial therapy that targets it. But for patients at low risk of infection, for the specific MDR pathogens, we suggest against using empiric antimicrobial therapy with coverage. And so I think this just reiterates what we've been talking about here, is that it's really understanding the individual patient in front of us. And they also talk about de-escalation. And so that many times patients may come in and it's actually, we're unsure if it's sepsis up front. And as time goes on, we realize that maybe something else was driving their presentation. And we can de-escalate or discontinue antibiotics at that time. And then for adults with sepsis or septic shock, they recommend de-escalating antimicrobial therapy over no de-escalation when we have a confirmed microbiological diagnosis, as well as when no pathogens are identified on final culture results. So that all aligns with this idea of even when we can't avoid being broad on day 1, we often can make a choice on day 3 or 4 to de-escalate. And finally, I want to review the diabetic foot infection guidelines. So this was also something that I think has been distributed to you before. And this very much relates to what we've been talking about and thinking about the patient risk factors for diabetic foot infections. In most patients with diabetic foot infections, we can avoid treating broadly. And so we're again thinking about more of, for example, strep species or even MSSA in most of these infections, and doing cefalexin for upfront therapy. For patients who have MRSA risk factors, we're going to be thinking more about broadening. And And again, this is for mild diabetic foot infections. In the outpatient setting, we still have a lot of options for different oral therapies, all that have different pros and cons on deciding. And even in moderate or severe diabetic foot infections, where we're talking about using IV antibiotics up front, many patients fall into this standard treatment category where they can really be started with something like ceftriaxone or amsulbactam and don't necessarily need additional coverage for Pseudomonas or MRSA. There are patients who have other presentations that will be more worried about potential Pseudomonas or MRSA, and in those cases, of course, it's appropriate to add those agents. And so to recap, my big takeaways that I hope you walk away with is that your thoughtful antimicrobial stewardship, both in the clinics and on the wards, really can improve your patients' outcomes. We're not just making decisions for the world, but we're making decisions for the patient in front of us. To that end, I think it's worth considering whether you can avoid initiating some of these empiric coverage, especially when your patient's not super sick, or the infection site and organism don't match, or the patient doesn't have risk factors for it. And in the event that you do have to start with empiric coverage, just to be thoughtful about avoiding inertia and reevaluating the continued need for broad spectrum antibiotics, because we really can make a difference for our patients when we're able to de-escalate. And that's all I have for you. So with that, I will take any questions.
Well, Dr. Cohen, thanks a bunch. That's really a nice overview, and I really appreciated you taking it into clinical scenarios about the different things. Dr. Pradhan has lit himself up. He's one of our local internal medicine docs. Dr. Pradhan, do you have a question, my good friend?
Yes, sir. Good evening, and thank you very much, Dr. Cohen. It was a great presentation. Couple of things. Antibiotic stewardship is important, and every day, day in and day out, patients do almost quote demand antibiotic because quote that makes them feel better. Now, and then the other aspect of that is there are many patients we have had suppressive antibiotic therapy, i.e., nitrofurantoin for UTI, or and then azithromycin for bronchiectasis. So, question I have is, as we treat this patient with the antibiotic, and we are disrupting the microbiome in GI tract, so could you please comment on how to regenerate the microbiome post-antibiotic uses? Now, there are times I have had people using antibiotic with a probiotic. Doesn't work. I know that, but then still we use it. There is a whole aisle of probiotic in the drugstore. They're of no use. So, can you comment on?
Gosh, it's a great question. And I don't know that I have a great answer for it. I agree with you. I certainly see patients use probiotics, and the data doesn't really support it. And maybe that will change with time, but at least right now I haven't seen any super convincing data on it. I think some patients feel better having that or doing that. I think there is some interesting data that's still quite far away from implementation, thinking about things like fecal transplants. Obviously, it's used in C. diff. There's some data emerging about its use in like recurrent UTIs as well. I would guess we're still somewhat far from that being a regular implementation, but I think it's something to keep an eye on. And then I think the other, to your point, that a lot of patients are on these for suppressive reasons. Is going back to are there opportunities to reevaluate if they still need it or if it's still beneficial? And I've certainly seen patients in my clinic who were started on it and it's no longer helping them. They're still having breakthrough infections, or perhaps they haven't had a trial off of it in a long time, and it can be an opportunity to talk through that, which I know is it can be a challenging conversation.
One more question. Thank you for the input. Appreciate that. I guess it's ongoing issues. We have to deal with it. Before 1940, we didn't have it. Now we're 2026. We'll have it with the MDR and all those things. ESBL UTI. If the patient is asymptomatic, is it legally okay not to treat?
Yeah, that's a great question. So I think of UTIs as a clinical diagnosis, and I very much strongly believe in not testing if there's no like clinical symptoms. So if a patient is asymptomatic and you have a culture, I would say that that's still just asymptomatic bacteriuria and it's not a urinary tract infection. And I would not treat it because they're likely colonized with that, and they always will be. And I think that that is well supported in the guidelines. And so, Dr. Mooring, I don't know if you have additional input on that, but I think that there wouldn't. I think there's a lot of evidence to support you in that decision.
Yes, we're going to talk about UTI test stewardship. So that's a perfect segue to the next.
Great
Thank
segue.
you.
Yeah, thanks, Dr. Cohen. Renee, are there any questions in the chat?
I don't see any additional questions in the
Thanks. All
chat.
right, well, Dr. Cohen, thank you again. Let's move on to the second talk. Many of you may already know the new concept that emerged almost 10 years ago about what's known as value medicine, meaning our being able to, as a doc or provider, choose the tests and the treatments we use that have the most value to the patient. In other words, not just testing for testing's benefit. There's that old saying now that you can't go to heaven without a CT scan, so to speak, in the ER, what used to be blood gases back in the day. But the whole concept of having stewardship about choosing the right diagnostic test is something that's emerged as a hugely important topic, which leads us into the second lecture or review this evening by Dr. Rebecca Mooring, who's from Duke also. Dr. Mooring has an interesting educational journey, having started at UNC Chapel Hill as a music major in the flute, where she actually graduated with highest distinction and was a member of Phi Beta Kappa. She went to the Virginia Commonwealth University School of Medicine in Richmond, where she again was a stellar student, being selected also for the AOA Honor Society. Her internal medicine residencies were at Northwestern in Chicago, following which she returned to Duke for fellowships in infectious disease. And then all this was capped off with a Master's of Public Health back at UNC Chapel Hill. She is a nationally and internationally recognized authority in infection disease and stewardship of treatment of infection. She has published over 92 articles, 8 book chapters. She's the medical director of Duke's antimicrobial stewardship and evaluation team. And she's also a co-primary investigator for the CDC's major multi-center studies on strategies to decrease healthcare associated infections and prevent antimicrobial resistance, so what are known as epicenters. We've had her teach us before, and we're delighted to have her teach us again tonight. So Dr. Mooring, thank you so much. It's all yours. I think you may be muted, yeah. We're seeing your slides. We're not hearing you. You're muted.
I'll unmute myself and share again.
Yes,
My
ma'am.
bad.
Yeah. Well, now we see you. You're unmuted. We just need to, there you go.
Okay, great. Thanks for the introduction, Dr. Moore. Really love to talk to this group and just remind you that I am a Virginian. I was born in Richmond, grew up in Virginia Beach. So, and I have lots of family that were in Danville. My parents met in high school in Danville. So I have a lot of connections to your area and love to come and chat with y'all about especially stewardship. So I will move forward if my slides will let me. There we go. I don't have any relevant disclosures. I know we already went through that, but I did just want to, disclose that I really consider myself to be focused on antibiotics in terms of my stewardship. And so this field of diagnostic stewardship is still relatively new to me, and something that's emerged with a lot of gusto out of the field of both infection prevention and stewardship. So I'm still learning these things myself and still gathering my experience in trying some of these strategies. So this is kind of one of the first publications that really discussed and like defined what diagnostic stewardship was. You can see it's dated from 2017. And this is from Dan Morgan, whose background is in infection prevention research, and he's at Maryland. And so he really kind of took this idea of, yes, we're stewarding our antibiotics, but we really need to be stewarding our diagnostics, because that's the decision first, and then the treatment decision is second. And if we can really improve the way that we make our infectious disease diagnosis, then we can really improve how we use antibiotics as well. So it's kind of like going a step up. So just the treatment decision, you're going into the diagnosis decision. So the definition of diagnostic stewardship, there are two here from a couple of resources. One is modifying the ordering, performing, reporting of diagnostic tests to improve the diagnosis of and treatment of infections and other conditions. The other is a little more catchy and more similar to the way that we define antibiotic stewardship, and that's ensuring the right test is ordered in the right patient at the right time for the right clinical management. So, of course, it's, you know, trying to make the best decision that we can around diagnosis and testing for our patients. And so the reason that this matters, again, is because the testing really drives our treatment decisions. And we know that more is not better in many scenarios. So if we over-transfuse, that's not good for patient outcomes. If we give too much fluid because they got a sepsis flag in the ER, we can drown patients' lungs with fluid. We know antibiotic overuse is also a problem. And so testing also, when we overuse that, we can actually cause harm to patients. And so our goals in diagnostic stewardship always are to improve patient care and outcomes and avoid harms. It has a downstream effect of influencing what antibiotics we use. But importantly, it also improves the efficiency of our care and our institutional costs in providing care to our patients. If we're not over-testing, we're not paying for those tests, we're not suffering the downstream effect of over-testing. And so that has a lot of benefits, both for an individual patient, also for the antibiotic stewards of the world, like I'm very passionate about. And then also our hospitals who are trying to provide efficient and good care. So the strategies involved in diagnostic stewardship really are outlined in a group of papers from the Society for Healthcare Epidemiology of America. And this is kind of the first one that really provided the schema of what is involved in improving diagnostic testing. And generally, we think of it most commonly, I think, in the test ordering space. So when a clinician has evaluated a patient, what can we do at that time of deciding to order a test to support that decision making? And so a lot of that is built into our electronic health records. Or it may be that we can provide a couple of process steps in ordering to make sure that the correct test is ordered. So you guys probably have radiology call you if you put in an order with contrast, and the indication is something that you don't need contrast for. You'll get a call and say, hey, you know, maybe we can do this without contrast, save this guy's kidneys today. And so I think we're really used to kind of having that feedback in a clinical setting, and many of those things are now incorporated into the EHR. The next is how we collect a specimen and transport that to the lab. And that's actually really important for infectious disease diagnostics because of the risk of contamination of a specimen. And so having those processes, including like our phlebotomy teams, you know, disinfecting the skin appropriately before we draw blood cultures, things like that can really affect both our test yield and also the confusing results we sometimes get from tests. Test processing and performance. This is actually the processing of the specimen after it gets to the lab. And so there's several strategies there. One main one we'll go through today of things that the lab can actually do to get rid of the process and the resources into low yield tests and identify those things. So we'll talk about a really good example of that today. And then also we can look at how we report that. back to our clinicians to be able to interpret that the best way to make a decision. But I think probably the most important thing is that we evaluate our patient first before we decide to go through the ordering process. And so that's all of what Dr. Cohen was talking about. Identify an infectious disease syndrome, understand the pretest probability of that patient having the diagnosis before we order that test. And so that clinical evaluation is like what we live for, right? That's like why we go into internal medicine or cognitive specialties. And so making that, a clear clinical decision is also a part of diagnostic stewardship. So moving on to this talk, I really want to talk about 3 cases for diagnostic stewardship, and we're going to hit the first one that came up in the Q&A on the last talk, and that's UTI. Then we'll talk about blood culture stewardship with bacteremia, and then I'm going to end up with molecular tests because this is an emerging, changing dynamic area, and I think is an area where many institutions are working, including my own. So we'll air a little bit of dirty laundry there. All right, so first on UTI, I will say as an antibiotic steward, this bogus UTIs, air quote UTIs, non-UTIs, whatever you want to call it, this definitely exists in our hospitals. And so we spend a lot of time educating our trainees, our APPs, our clinicians in the hospital about what it is, what is a UTI. And we have been talking about this for years and years. And so kind of the 3 main criteria is there must be symptoms. So that ESBL colonized patient with a culture but no symptoms, that is not a UTI, right? And so those symptoms must be dysuria or suprapubic tenderness, for cystitis, for upper tract infections, fever, CVA tenderness. And importantly, does not include odor or appearance, which is a myth that we've been trying to debunk for years and years now. Second criteria is inflammation on the UA. And clinically, we use a cutoff of 10 WBCs per high-powered field on the microscopy, or leukocyte esterase of greater than or equal to 1. And then you've got to have a positive culture to really definitively diagnose the UTI. And we know that cultures do have limitations when we run into contamination events or patients already on antibiotics and we didn't get the culture early enough. But these are the main 3 things that we've been kind of beating into the trainees at Duke for years and years. And so we were so running into these so often in our stewardship work, daily stewardship work, that we actually created an electronic alert where, like, if a patient had an indication, an antibiotic order with a urinary indication and a UA with a white blood cell count less than 10, we would flag those to come to our team so we could call that person up and talk to them about, like, do they really have a UTI? What are their symptoms? What other things are on their differential? And so we found that when we made this, like, we definitely sped up the time that we got to these scenarios, but we also learned that it wasn't as clear cut as we had been beating into everyone as we looked at these patients. And so we actually identified some of these exceptional scenarios, and I have like the 3 main ones here. But we learned from this experience that, like, okay, this logic-based thing, it works for, the vast majority, but there are some of these exceptional scenarios. And the main ones that we saw in our hospital were neutropenia, where patients didn't have enough white cells to actually spill into their urine. And so that pyuria criteria may have been negative, but that's just because they had no white cells. The second one was for urology patients or patients who had obstructive stones. All the infection was above the obstruction, and we collected the urine from below the obstruction. Sometimes those pyuria screens were negative in those scenarios, but the patient definitely had infection above that obstruction. And then this third scenario is pretty rare, but we do see it sometimes when there's trauma associated with, like, hematuria, be it from a stone or a trauma Foley scenario. And the patient already has some asymptomatic bacteria and is kind of colonized with the bacteria. you bleed into a place that is colonized, you can actually get a bloodstream infection. So that's also kind of like another scenario that's like, yes, that's rare, but it doesn't mean that like this cutoff of 10 like uniformly covers every clinical scenario. So we learned from this experience and really use that to develop our next kind of steps in stewardship strategy. Mike Yarrington, it works with me. He's an ID doctor, but he's also trained in informatics. And so he helped us really work on the test ordering process to develop an ordering panel that kind of went through a logic tree to try and carve out some of these patients that we would evaluate differently for a UTI, but also to incorporate and make sure everybody had a UA before they got a culture. So in this first round of doing the order process, we wanted to make sure that we had that data from the UA to then be able to interpret the culture results after that. And so it actually promoted collecting UAs along with the urine culture. And the effects of this order panel was that we saw increase in UAs at first, and then overall testing went down. Overall urine culture rates went down as well because we were bringing in the UA results like right at the time of order entry. And then we also saw improvements in our GU indication antibiotic use. So this was a success for us. But we still had a ton of people that we were doing our alerts for and calling up and talking to them about their UTI diagnosis. So this was kind of the next step in our journey, and that was to look at conditional urine processing. And this is actually one of the strategies discussed at length in the Shea white paper on diagnostic stewardship, because it's a really impactful strategy for reducing urine culture rates. You may hear it referred to as reflex cultures or culture with reflex. You have to be careful how it's named in your system, because if you have a UA with reflex to microscopic, some people can confuse that with the reflex to culture order. Other institutions have used the terms that I said already, the pyuria screen, to try and communicate that at the time that folks are putting in orders. But basically, the idea is that you have both the UA and the urine culture, and you use that negative predictive power of lack of pyuria to then make a process within the lab where if there's no pyuria with that paired UA, that urine culture specimen doesn't move on to processing the culture. So there is a little bit of stickiness here when you're trying to do this in your lab. The main thing is that it is mostly implemented on the lab side, but it takes a ton of like front end work and buy-in from engaging a variety of clinical groups. Basically, every clinical group that uses that lab probably sends urine cultures to them. And it takes a really good coordination between like two different parts of the lab. So not just the micro lab, also the chemistry lab. And then you have to have the specimens like together. So in our system, we have like the urine, kind of like two tubes, one for the UA and one for the urine culture. And so those two tubes have to be sent together as a group to the lab at the same time. So using that reflex culture, actually, if you look at the literature, and this is from that Shea paper at the bottom, you can see that it will reduce the urine culture rates in the processing of the lab by like 20 to 30% in what's been estimated. It may or may not result in a decline in the antibiotic use for UTI, and that really depends on how much your clinicians were at baseline treating patients without pyuria. So this picture on the right is an example of the scenario that it was at my hospital. This is like our stewardship team. We're teaching our clinicians to ignore bogus UTIs and be confident about not treating folks without pyuria. And then meantime, our lab is still processing dutifully all of those urine cultures. They were literally drowning in urine before we were able to implement conditional urine processing. So it's not just about kind of like being in line with the clinicians and the stewardship team. It's about also like considering that resource investment from the lab. And then for conditional processing, it doesn't much affect catheter-associated UTI because that pyuria screen cutoff doesn't work as well in those patients just because those folks are going to have some amount of pyuria due to the catheter itself. And so if you're looking for a catheter-associated UTI project, conditional urine culture processing probably isn't the strategy to use. There is this cool study from Kim Clay. She's also from Maryland, where she actually went to 3 of the VA hospitals and engaged them in kind of qualitative work, just like trying to understand what types of strategies would work in their hospital. And she asked them to select one strategy from kind of like that paradigm of diagnostic stewardship, whether an ordering focused strategy for diagnostic stewardship, something in processing, or in the reporting side. And for one of these hospitals, like going to conditional urine processing was just like flatly declined by the hospital. People were worried about that. They were worried about missing true infections. And so they ended up choosing a different strategy. I also think it's important to realize just how many hospital admissions are related to UTI. So it's like more than 10% of, or 12% in this study were related to UTI antibiotics. So that's like a big chunk of patients in the hospital. For the strategies chosen, you can see that these 2 didn't have any change. And the one that had the most change in both the antibiotic use for UTI as well as the culture rate was this conditional or reflex urine culturing. And so it's interesting to see this effect and also to talk with Kim. She actually was interviewed on one of our DASON podcasts, and Melissa Johnson, one of our pharmacists, asked her, she's like, so of these 3 things, what was the hardest to do? Like, what was the hardest to implement? And she was like, absolutely, conditional reflex culturing was harder to implement because of all the upfront work and the lab processing part. So it's not the easiest thing, but it potentially is the most impactful thing for the lab. All right, I wanted to give you an example of a strategy where they kind of combined those 2 steps in the strategy kind of continuum that I gave you, both at the ordering side and the processing. So this is from the University of Nebraska, and they implemented a conditional urine processing strategy. But they also used the ordering process to gather data that was then later used by the lab in the processing part. They laid out everything that they were going to do at the top of their order set. And then they also asked for an indication. So this is basically a pause for the clinician to be like, okay, what symptoms did my patient have? There is an other option here, so it doesn't have to be suprapubic or CVA tenderness. You could write in another option for the indication. And then they also identified those special populations. So some of those patients that we saw when we were just doing our case reviews at Duke are in here. So folks that are post-transplant, they have an upcoming urologic surgery or are pregnant, and those are kind of like your 2 scenarios where you actually would do asymptomatic screening prior to those events. If they're neutropenic, peds. So those special populations kind of went straight to, to jail. I don't know, to culture. They, if they were in one of those at-risk population, they kind of skipped the processing steps. But otherwise, this processing steps were very much based on the symptom description, the squamous cells, the UA, WBC criteria, and then the lab decided whether to process based on those things. And so this is just an example of how you can kind of incorporate both of those things. And so this is the outcomes from all that work at Nebraska. And this is over a huge time period prior to their panel on urine culture processing going live, post, and then post it going live and COVID. But the main thing to see is just their urine culture rates like really dropped when they turned on this process. They also worked really hard to get their catheter use down, like during that whole time. That was more of a gradual effect. And then ultimately did see improvements in their catheter-associated UTIs with that as well. I know that one of the authors on here, and he said this was like the hardest work that he's done in his career. And he's actually published a lot of papers, but he was so proud of this paper just because of like how long it took to be able to get it done, and then the size of the impact. So there are some challenges when you think about urine culture stewardship. I think that the main one is just like a safety concern of missing a true infection. The second one is related to that because I think some clinicians find it hard to kind of like buy into this idea of conditional processing by logic. And so some of the approaches that I've seen folks use to kind of like get that buy-in is to actually do a local assessment of patients in their practice setting, either a retrospective or a prospective review, see if they would have had any burns for patients that they would have applied that criteria to. And then I think the other approach is to kind of do it incrementally. And that's the approach that we had to take at Duke, actually, where we started with a lower UA WBC cutoff of 5, and then we hope to go to 10 in a future year. So even the 5 had a big impact for us. It dropped our urine culture rates by about 20%. So even if you can only get to 5, you know, take what you can get and then try again the next time if you want to be more strict about the UA criteria. The special populations, I think I've honed in on these already, but I think it's really important with any system change to include these folks in the conversations, and you may need to carve out special processes just for them. And I think I gave you good examples of that. And then anticipate other potential harms. You know, will people stop testing and just treat people empirically? And that, you know, kind of defeats the purpose of using this as a strategy to decrease antibiotic use. Or, you know, maybe in your process, you actually may cause harm with Foley trauma in your urology population. So whatever you have, especially in your EHR builds, anticipating the negative consequences is really important. I did want to highlight that conditional urine processing is in the docket for Sovah. Before this talk, I sent some questions over to the lab and to Linda Crane. And so I asked, are we doing conditional urine processing at Sovah? And it was, we're working on it, a reaction. LifePoint does have a policy in place, and I think we're in the, let's get buy-in from everybody and make sure that it fits here in Danville and Martinsville the best way. I will highlight that the components that I showed you from the literature are all in this like proposed policy from LifePoint. They're slightly different than the ones at Nebraska and Duke, but you need to have customization to your hospital. And so the special populations are listed here. They have pregnancy, urology, and immunocompromised. The indication has kind of a longer list of bullets. And then these processing criteria, it looks like LifePoint's going with 10 to start, and then looking at squamous cells. So similar to the Nebraska approach and the reflex criteria. So coming your way soon, but still in process. All right, I wanted to switch and talk about blood culture stewardship because there is good data that we can reduce blood culture use rates safely and effectively. And these are 3 studies from the white paper that highlighted some of these effects. There are some big downstream effects of overusing blood cultures. And here are kind of the main ones. I will say that a lot of this strategy came out of pediatrics. And so in the little babies, if you test their blood too much, you can actually make them anemic. We worry about that less in adults, but when we start collecting 30 to 40 mils per blood culture set, like it actually can have an effect on folks losing blood in the hospital. And so here's some of the estimates from some of that, effect. Also, we have issues with blood culture contamination. So I mentioned, not sanitizing the skin before we collect with phlebotomy for blood cultures. And so there's literature around this that it not only causes confusing results and things like that, it causes you to order more blood cultures It can actually lead to like removing lines that may or may not have needed to be removed, canceling surgeries. It can actually lead to surveillance definition for a central line associated bloodstream infection, which is one of our patient harms that gets tracked and reported externally. And then, of course, the most important to me is like it results in a bunch of vancomycin days that we probably don't need when we're dealing with contamination. So all of these things are things that are downstream effects, especially when we're overusing blood cultures. For blood culture stewardship, there is now like more than 6. This slide isn't comprehensive, but these are the main ones that if you do, develop a blood culture stewardship strategy and intervention, you can not only reduce the blood culture rates, it actually increases the positivity rate. So when you do culture, the percent of cultures that are positive also goes up. It can reduce broad spectrum antibiotics and reduce those CLABSIs that we're trying to avoid. But importantly, in this literature, it's shown that there's no adverse effects. No people dying because we didn't get their blood culture, people not staying in the hospital longer, readmissions. And if you are regulatory focused and you're worried about CMS SEP1, the compliance with that core measure also wasn't negatively affected when they did these stewardship interventions. But what they did do is reduce the number of blood culture used by like 20 to 40% in these. This is the study that is from the kids, and it's actually after their pilot data, they actually implemented the blood culture stewardship strategy in 14 different PICUs across the US. And you can see that they decreased the overall blood culture rates by about 1/3. And in concert with that, they also saw reduction in antibiotic use, reduction in CLABSI events, and none of that difference in those patient outcomes that we worry about. So not only did it work in one hospital, they were able to do it in 14 different PICUs and saw those results. This is the data from adults, and one of the first blood culture stewardship papers came out of Hopkins, and Valeria Fabre, I think you'll see her name at the corner of many of these. She's been really doing hard work in diagnostic stewardship. So at Hopkins, they basically did education with a algorithm, and then did routine feedback with providers in their medical ICU and medical units, and saw declines in the blood culture use rates that we described there. So I wanted to go in and be like, just describe how these the education around bacteremia is structured. And it really came from this big, systematic review that Valeria Fabre did kind of in the COVID times. She went through all the literature and then categorized the different infectious disease syndromes and kind of like some of these reasons that we get blood cultures into these major buckets of pre-test probability of bacteremia. So again, we're trying to determine which patients are likely to have a bacteremia before we determine who needs a blood culture. And so if you look at this, you can see that the very, very low opportunities are the folks that have just like one fever in the hospital or have like one fever after their surgery. Those folks probably would benefit from avoidance of blood cultures. And then on the other end of the spectrum, we have folks with septic shock, folks that have like lines, and then the other things that we really do need blood cultures to be able to identify the pathogen. So those are the folks with vertebral osteo, epidural abscesses, septic arthritis. And then kind of in the middle here, we have some that are low, that are non-severe CAP, lower UTI, and then kind of the opposite, patients that have like more severe infections, more invasive infections, severe CAP. So these are your ICU patients, and then folks that have clear evidence of pyelonephritis in the moderate group. And so basically the algorithm for blood culturing really kind of identifies these syndromes are ones that like you should routinely obtain blood cultures in. These are the ones you should routinely avoid, and then look for, if you can, more focused culture to that site of infection. And then there's some in the middle where, you have to kind of make a judgment call and individualize that decision. I know you can't read this, but this is the Duke version. the blood culture diagnostic stewardship algorithm that we developed. It takes the major concepts from the work at Hopkins and then kind of individualizes that to Duke. We have a lot of invasive strep that comes our way and endocarditis that comes our way and experts in those areas. So we needed to adjust our approach just slightly from Hopkins. But we were able to successfully implement our decision tree education-based algorithm in many of the units in our hospital and in our health system. And the person that really championed this work is pictured here on the slide, Jessie Seidelman. And she just had her hair on fire and went to our ICUs primarily. She works in infection prevention. And in our SICU and our CT ICU, she saw the rates of blood culture drop like precipitously there. And again, didn't see those negative events. As an add-on to this, we did some blood culture stewardship in our EHR. And so this is a picture of the order set that Mike built where we link to that algorithm education. We pull in data about whether a patient has a central line into the ordering process so the clinician can see that at the time that they're ordering. And then importantly, all of our options here don't have any options for a single blood culture order because that's one of the practices that we were trying to discourage was single blood cultures because those are really hard to interpret when you get a coag-negative staph in a single blood culture. You don't know whether that's a contaminant or real. And so that was one of the goals of the update. It includes the syndrome-based risk assessment there on the left side, color-coded for that high, medium, and low risk scenario, and then had some questions in the order entry process where if the patient had suspected sepsis. And so we learned a lot of things as we implemented this. We found that the most common reason for avoidable blood cultures was that single fever or leukocytosis. And that's in that very low pretest probability. And when we reviewed those cases, we didn't find anybody that would have been a burn, right? Every case that we reviewed either had negative cultures or they had a contaminant organism that really didn't improve their care. We also observed some other low yield practices, and I'll just read them out very briefly. The thing called the full fever workup, which again, if somebody has an isolated fever, that is the knee-jerk reaction to just like get 2 blood cultures, a urine culture, and a chest x-ray without evaluating the patient for an infectious disease syndrome. And so that's kind of a bad word for us. You know, you don't say that because that basically indicates that you haven't thought about the patient and you haven't really fully evaluated what their signs and symptoms of. So don't use that word, okay? All right, we also saw some culturing just because they were transferred or they showed up. And then we also saw blood cultures drawn too early. So really, when we want follow-up blood cultures after a positive, we want to wait like 48 hours before redrawing, and that gives our antibiotics time to work, and also the prior cultures to mature enough to know if it's positive or not. And then the final lesson is trying to avoid central line draws. This is an example of how we fed our data back to our medical and ICU wards. We not only provided like their trend for utilization and the percent abnormal, but we also reviewed cases and gave them like the case specific feedback when we thought there was an opportunity. So this example here at the bottom is just like a patient who had neck pain, failure to thrive, admitted with hypoxia, and aspiration pneumonia, intermittently requiring higher O2, and then getting culture during that time, even though it was clearly a respiratory issue and they didn't have severe infection at that time with physician documentation of mucus plugging and aspiration events. So they had a clear explanation. The patient didn't have even have a diagnosis of pneumonia after their initial stay. So that's just one example. We had some successes. There are some challenges with stewardship, and I think the main one is sustainability and scalability, as well as just competing priorities for our attention. And so we are still trying to keep this work going, though the enthusiasm of when Jesse kind of started this has definitely waned as we've had other priorities. And I think this is a challenge with all QI work, to be honest. And so we're still doing this work. We still have the EHR-based decision support, but the enthusiasm for the data feedback and getting that back to our providers is less prevalent now. All right. I don't have much time for molecular test stewardship, so I'm going to go as much as I can through this last part. I think the main thing to know is just that there are a lot of multiplex PCR panels coming. So I know that at Sovah now, you already have PCR for positive blood cultures, the BCID2. You have a PCR test for group A strep. You have a PCR test for diarrhea, the GI panel. And then you also have a lower respiratory tract panel. So you already have 5. There are actually even more. Some of these actually test for targets that we see rarely in clinical practice or we think about rarely. So this one on the right is a STI panel, so sexually transmitted infection panel. And if you look at those, you probably recognize number 1, number 2, number 3. And then number 4 is probably one you haven't thought about unless you're an infectious disease doctor or you've worked at a STI clinic, because it goes into the syndrome of non-gonococcal urethritis. And so we don't typically test for that. We just treat non-gonococcal urethritis. And so having that test come up with that result was like a surprise when we implemented that. And so we had to deal with that issue in our health system. And Mycoplasma genitalium is actually not easy to treat. It takes 2 full weeks of antibiotics, 7 days of doxycycline, followed by 7 days of moxifloxacin. Patients that got tested and found mycoplasma, some of them were pregnant. They couldn't really get quinolone. So it caused a lot of stress for folks that weren't expecting to get that result. So there's a lot of advantages for molecular PCR tests for the lab. It's fast. There's the same instrument. They can batch it. A lot of it can be automated reporting as compared to older methods that are really long and resource intensive. You can also include targets that are harder to grow in the lab that we wouldn't have necessarily even known about in the past before these tests. It's rapid, it's really highly sensitive, and it can also incorporate drug resistance targets. So in the BCID2, for example, as soon as the blood culture grows, whether it's MRSA or not. So that's really helpful when you're trying to make antibiotic decisions up front or when, maybe your patient wasn't covered for MRSA initially. The downsides is it is more expensive, but it's actually can be cost neutral for the inpatient lab. There is some variabilities on whether payers will cover these tests, especially in the ambulatory setting. So you have to think about that beforehand. Mycoplasma is one of the examples where we didn't discover that Blue Cross Blue Shield wasn't going to cover that test until people started using it in our clinics, and then we got denied some coverage. So that's an important thing to think through. Also, I think it makes clinicians think less when they're oh, I'll give them a pneumonia panel or I get the STI panel. It may cause clinicians just to be a little bit lazy about getting signs and symptoms and a full history. And then I think that the main one that I'd like to highlight is just the possibility of picking up subclinical or asymptomatic disease. So these are extremely sensitive tests. And so just like Ariel said about the MRSA NARS PCR, you may pick up dead bugs with that. And so that can be an issue, especially if you're over testing a group of patients that have no convincing symptoms or are completely asymptomatic. And then finally, folks can be unfamiliar with the targets, and some of those targets don't require treatment. And so this is just an example of the GI panel, and some of you may have been the recipients of some of these results and had to look up, okay, what exactly is cyclospora and how do you treat that? And so I think, or what's the difference between EPEC and ETEC when that's reported out, and you have to understand what the relevance of that is. So I think, one of the most important things when thinking about this and when we implemented it is that we really are not intending these for patients with diarrhea who otherwise would get better on their own with just supportive care. And so that's our treat and release population in the ED. That's our outpatients, majority of our outpatients. Of course, our immune compromised population is special. I think the other thing is that just like a ton of these just require supportive care. They don't require any antibiotic treatment. But when you see that your bug, you want to squash it, right? Even if it's not going to harm you actively. So we created this diagnostic algorithm to help our providers, and then also a panel for a management table split up into the targets that really would require treatment up here, so like Salmonella and Shigella, versus thing where like you really wouldn't treat unless you had a special circumstances. So Campylobacter is an example of that, and then provided some therapy options there. So I think like in interpreting these tests, you have to be careful, because if you test a bunch of people that don't even need treatment, that's just going to steer you down the wrong path and potentially lead to more antibiotic use. All right, I'm going to have to skip a lot of C. diff because I don't have time, but just know that this is an area where we really developed a lot of our strategies for stewardship, testing stewardship in general, because it was one of the first molecular tests that we used widely in patients with diarrhea. And there are just a lot of people in the hospital with diarrhea not due to C. diff. And so when we use this strategy with just the PCR and not the two-step, we pick up a lot of folks that actually don't have significant disease or don't have toxin-producing disease. And so there's a lot of things in the literature on how to address C. diff. I think the main thing that I want you to know is just that a two-step test, it makes a huge difference in antibiotic use rate. So not only is the C. diff there, but is it toxin producing? And you can see just from our local data and in our network of hospitals how that our use of and treatment of C. diff once we made that testing change dropped by half. All right. So for molecular tests, I would say you need to be really thoughtful about who you really need to test and if it's actually going to change your syndrome-based management. I do think that using institutional guidance like the GI panel guidance document that I showed is helpful. And I think the other thing is just as a clinician, you're going to want to know what's on the test and know what to do if one of those come back positive. And so being able to put that within the context of your patient's presentation and to be able to then explain it to the patient is really important. I did want to highlight, I know we're at the end, I think, Mike, but I did want to highlight some of the resources that are actually available that your stewardship team has worked on that is on the intranet. It shows you where to go. It's under pharmacy there. And then here, for example, is the institutional guidance for the BCID2 targets. So it not only helps you interpret like the detected, not detected reporting, but also like which empiric antibiotic to use based on your local data from your antibiograms. So hopefully I've convinced you that diagnostic stewardship can have really big effects in antibiotic use, but also test use and lab costs. There's also workflow benefits, and it can actually help reduce some of the noise and the cognitive burden and evaluation of our clinical data. There is some balance that we need, especially if we have special populations that you need to consider in creating the strategy and the risk of harms in that patient population. But then I think the other thing is that this work has been really just fun because of for me at least, because a number of collaborations across different clinical groups. There's like multiple and varied benefits for each clinical group that's working to improve their patient care. And I also like to see just incremental change. Like we change our order set once, we're going to change it again to like make it even better each time. So that can be really, really gratifying for someone that's interested in this topic. So I'm going to stop sharing and see what questions we have. I know I went over a little bit, Michael. Sorry about that.
No, you're fine, Dr. Mooring. One thing before we ask them, we're going to get the questions. Everybody hang on 1 second, because I want to make absolutely sure everyone on the call heard the earlier announcement that you must put your name and your email and your professional type in the chat so we have a record that you attended tonight. If you do not do that, we don't know you were here and you will not get credit. So thanks for letting me interrupt with that. I think we have some things in the chat. Vinay, you want to read those? I know Dr. Vazzaretti had one put up there, please.
Yes, Dr. Vassaretti put in the chat, an elderly lady gets admitted to go through the ER with sepsis and suspected UTI, responds well with IV fluids and empiric antibiotics with a great clinical recovery, almost back to baseline. Later on, urine cultures come positive for resistant organisms. Only sensitive to vancomycin and damascene. I might be pronouncing that wrong. At this point, the patient had no symptoms and she is back to baseline. Should she be treated with one of those high-powered antibiotics?
Yeah, so I definitely see this coming through. VRE is definitely one of the more resistant organisms, but it's also one of the wimpier ones in terms of causing clinical disease and like a really blazing sepsis. So one of the questions for this case would be, what was the patient treated with initially? And did that include VRE coverage at that point? And if the answer is no, and the patient is fine with the empiric coverage that you chose before, this urine culture is likely a distractor and not the primary cause for this patient's sepsis. So there's some infectious disease doctors that believe enterococcus doesn't really cause UTIs like ever. I've seen it cause UTIs in invasive disease from the urine tract. So it's not like I think it's a nothing, but it is probably one of the most common low virulent organisms that we see in asymptomatic bacteria.
Other
Great
questions?
question.
Are there others from the chat, Vinay?
No, there are no other questions in the chat.
Well, let me ask a question. There are surgical centers that routinely do nares, nose cultures, thinking that if they have MRSA, they're going to do something about it. If that patient is asymptomatic, doesn't have an inflamed nose, et cetera, and they just have a culture that comes back MRSA, is that something that should be treated and the surgery held until a course of antibiotics is given?
Yeah, so that is a topic that has a lot of data behind it. So, and the reason for doing the screen is to understand if the patient is colonized with MRSA, because that can then inform whether you put them through a decolonization procedure.
Right.
And use MRSA coverage like prior to their surgery as part of their prophylactic antibiotic. So it's less about identifying infection in that scenario as trying to reduce risk prior to the surgery. I will say that the process for doing the screening can sometimes get screwed up. And so there is a lot of folks, and I would say that Jessie Seidelman at Duke would tell you this, is that she basically suggests that our surgeons for high-risk surgeries, like those with implants, vascular surgeries, things like that, they do universal decolonization. So giving people the Hibiclens bath and the mupirocin, no matter what their mercenaries showed. And the reason for that is that decolonization not only could prevent MRSA infection, but it could also prevent MSSA infection, which is also like the major, surgical site infection pathogen. So that would be a great topic. Like if you have a big surgery group, Jessie would be an awesome speaker to talk about prevention strategies prior to surgery.
Let me ask you one other question. You mentioned the fact that too many blood cultures can be a problem, and one of the problems is that basically it's a contaminated stick. They went through they had a pathogen on the skin that got picked up with a needle going into the vein. What's the current recommendations for skin prep before blood cultures? Betadine, a vigorous alcohol, what should that be currently?
Yeah, so I believe it's got to be alcohol containing And there is a time limit on that. I didn't come with those recommendations here, but I can get that to you afterwards. I do know that for phlebotomists, they have to undergo training and like observed training for compliance and preparing the skin.
And that's done here, absolutely.
Yeah, yeah. So, and then 2 peripheral sticks is the recommendation. So 2 separate areas of venipuncture, 2 sets of blood cultures, hopefully with 10 mils per bottle, to get the best yield from those blood cultures.
Right.
If you're going to stick somebody, get the blood you need, so that the test actually works.
So it's not one stick and then put it in 2 bottles.
So 1 set of blood culture generally has 2 bottles. So 2 bottles from one venipuncture, and then 2 bottles from a separate venipuncture.
And you also mentioned the concern about drawing from a central line.
Yes.
And I suspect that's with all the vigorous efforts to clean the port size or the connector. That still is not as good as doing percutaneous if you can.
Exactly. Yeah. And I think like those, when you draw from the line and you get a contaminant organism, 1, it's confusing, right? You don't know if that was really the thing that was causing, or if it's a contaminant. 2, it can actually lead to pulling out lines that don't need to be pulled. And so like that is a potentially very harmful event.
That's a bad situation. Yeah.
Right. Right.
Absolutely. Do we have other questions for Dr. Mooring? I know Dr. Cohen's still on also. Any questions? We have a lot of our wonderful laboratory staff and quality folks on the call. So this is your chance. You're among friends. You either speak up or put it in the chat. And
Hi, Dr. Moore.
Yeah,
Dr.
please.
Moore, I'm Catherine Parker. I'm the administrative lab director.
Yes, ma'am.
And we've been working really hard with our phlebotomy team on blood culture contamination rates. But I just want to tell you right now that we are actually drawing a diversion tube. So we're drawing a diversion tube before we draw the blood culture, and we clean with ChlorPrep vigorously for 30 seconds before we draw the diversion tube or the blood culture. So we have really seen some success with our blood culture contamination rates. We were actually in January at 1% on the Danville campus, which was really, it was really good for us. I think we crept back up to like 1.8 in February, but our quality team had done a great job as well, walking around and watching phlebotomy and just making everyone drawing blood cultures aware. So I am super proud of our quality team for what they've done with that. We still have a ways to go, and it's not a perfect process because staffing is always a challenge and everybody's always in a hurry. But I am really proud of how far we've come.
That is a great success. And it's multifaceted, right? I think that it's amazing if you have phlebotomy services that are kind of a tight-knit group that like know their craft. I mean, I think like that is the biggest difference. We do see like in more hectic practice settings like the ER, the contamination rate is harder, and that's kind of related to the environment, but also different users. So often like nurses have to draw cultures in that setting. So the staffing and the resources for doing that process can be the limiting factor for sure.
Any other questions? Thanks so much, Catherine. Are there any other questions, comments, or concerns this evening? Okay, well, we right on time. I thank the speakers for their timely presentations. We're delighted to have had them both talk with us tonight. And I hope most of you will be back in 2 weeks to hear Nick Turner talk about tuberculosis and its a remarkable increasing prevalence that's occurring in certain communities. That being said, let me remind you one last time, if you hadn't put your name in the chat with your email address and professional category, we need to hear from you so we can send you the the CME certificate after we get the eval form and all. So thanks to our two great speakers. We hope everyone has a great night. Thank you so much. Take care. Bye-bye.